Serous retinopathy. As you all know, central serous retinopathy is a very, very common disease which occurs in young adults. Yeah, sir, start kar rahe na. You are starting. Sir, you will be starting? Yeah. So, as we all know, central serous retinopathy is a very common disease in young adult males, and very often it is at the height of stress that these people have it. And it's a very common problem, and Dr. Lalit would be talking us all the tricks how to manage that patient as well as how to evaluate him properly. Over to Dr. Lalit Verma.
Good morning to you all. Thank you, Gopal. This instruction course on macular disorders, in fact, is a repeat course, and we have been doing this course along with Dr. Avninder, Dr. Malika, Dr. Gopal Pillai, Raju, and I'm thankful to all these co-instructors for delivering very nice talks, therefore included them again actually. The thrust of this course is to give you an overview of macular disorders which can sometimes spoil the result of a cataract surgery. You see a lot of people, come that cataract has been done, but some of vision is not there, or the pre-op evaluation has not been done well. So the aim of this course is to let everybody know or interact and discuss that there are some disorders which can be treated very well pre-operatively or after cataract surgery, so that patient has the best kind of vision. I'm thankful to all this faculty, and we'll be talking on very, very common problems, and it will not be a theoretical course. It will be primarily how to approach this patient of, say, CSR or CNVM. So I'll take this liberty of starting this very, very common. When I was a resident, people used to use this term of macular edema because they used to see this swelling here, macular edema. So it was interchangeably used. So believe me, CSR is a detachment. It's not a macular edema. And CSR now, with a lot of increase of knowledge of choroid, it's a choroidal disease actually, and it is included under what is we call as a pachychoroid spectrum. And the entities which come under this pachychoroid is central serous retinopathy, pachychoroid pigment epitheliopathy, neovasculopathy, and PCV. And by definition, pachychoroid has three components. One is that choroid is thick. Second is that there is a dilatation of outer vessels of the choroid and attenuation of the inner. We all know choroid has three kinds of vessels. One is choriocapillaries, then is the small vessels, then is the large vessels. What we call smaller is Sattler's layer, S is small, Sattler's layer and Hallard's layer. So if you see this choroid, the inner layer, that is the choriocapillaries, and the Sattler's layer is attenuated. If you see Hallard's layer, that is the large vessels, are thick. So this is what is known as pachychoroid. Pachychoroid has three features: thick choroid, dilatation of outer choroidal vessels, and attenuation of the smaller and medium-sized vessels. So CSR term is existing for a very long time, but clinically what all of us should remember is it's a idiopathic kind of disease. It's a macular detachment, as I stressed. It's not macular edema at all. And whatever associations we know, these are associations, they may not be present in all of them. Let's say type A personality are more prone. It's related to increased levels of steroids in the blood, whether it is endogenous or exogenous. And we scientists do not know what is the good level for, say, you or me, but level in me may have more threshold, so anybody can have that CSR picture. And association of hypertension is also there. So diagnosis is by and large clinical. We see the central blister, but everybody should be seeing the inferior margin, because there have been reports and blunders by everybody that inferior margin is sometimes not seen, and inferior detachment can be sometimes mistaken. And the classic picture is that with a small plus addition, most of the patients of CSR will improve, say, from 624 to 6/12 or 6/9. So this is clinical. Investigation point of view, we all rely on these imaging techniques. This is an angiogram of a patient of suspected CSR. You see this, a swelling here. And if you see angiogram, there are three hyperfluorescent patches here. And this one and this one are not increasing at all. But the central patch is showing this smokestack leak, because this is increasing from pest. And all angiograms should have various frames, at least 9-10 pictures so as to interpret. Don't jump to diagnosis on one frame. You see, this is an early picture, this is a late picture. These two are stationary, but the central patch has increased. So it's a patient who has an active CSR now. And OCT shows very clearly, very impressive photographs. Here you see this neurosensory layer is here, and this is the RPE, and this is black is the fluid here. This is a classic CSR, but CSR could have variants in the form of typical CSR or atypical CSR. Then, depending on the number of leaks, we can have single leak or multiple leak CSR. Single leak itself could be ink block, smokestack, or sometimes ulta, that is inverse smokestack. Based on size also, we could have typical CSR or a giant CSR, where you have a huge balloonous kind of detachment, which has been sometimes operated also unnecessarily. And based on chronicity, you can divide CSR into acute CSR or chronic CSR. So one was typical CSR. These are variants of CSR: leaks, multiple leaks, giant CSR, acute CSR, or chronic CSR. This terminology should be very well understood by all. So coming to the most important part, after you have diagnosed, you have done imaging, you come to the treatment. And if the patient has come to you for the first time, you ask him, it is for the first time you are happening, because a lot of these patients have recurrent CSR, recurrent episode. So if it is the first CSR, first time, after you have done those investigation, treatment is just give him some kind of lubricant or maybe some drops. Masterly inactivity, because natural course of CSR is pretty good. Unless the patient is, you say, a pilot or a surgeon who is very, then you may intervene early. But by and large, the treatment is masterly inactivity. We do all this baseline imaging to tell the patient that he has a disease which is active, but simultaneously ask these questions: that are you using the steroid? Steroids may be in various forms, either oral, or sometimes patient may be having this Ayurvedic kind of tablet, which do not know homeopathic tablet, what do they contain, or inhalers, skin creams, they all may. Even all this have precipitated CSR. So this patient has this ink blot leak, which is revealed on this angiogram, and after a couple of weeks, it undergoes spontaneous resolution with no treatment at all, and even this OCT picture shows this. This was an acute CSR first episode. If patient comes with repeat episode or a recurrent CSR, or the first episode is not resolving, it has gone to chronic phase, then what should be the approach? At that time, what I normally do is repeat the angiogram, localize the leak. Why we want to localize the leak? Because if it is laserable, I tend to laser that patient. This is only for recurrent and chronic CSR. And if it is leakage in the safe area, normally we see the sacrosanct on the angiogram, the black area or the foveal FAZ. At that time, I tend to place few gentle spots of laser. Even sometimes 3-4 spots may suffice, but the spot should be a reasonably large spot. Do not use 50 microns of this, because it has a tendency to rupture the Brooks membrane. So smaller spot size, a bigger spot size is preferable. So this is one patient who has had this leak here. This is the laser spot which has been placed here. And you see, after treatment, this fluid on this thing is gone. This is another patient who has in the right eye leakage far, far away, and the left eye is closer to the papillomacular bundle. In the FAZ. So this was the left eye which we lasered. You can see the spots, laser spots here, and the fluid has decreased. Patient's symptoms have improved. In the right eye, we were very bold to do this laser, and the fluid has absolutely gone. So this is pre and this is post. This was the issues when the leak is far away. That is, leak is laserable. What about patient if he has leak in the central sacrosanct area from where all of us see? So whenever you have this picture, various treatments have been described. So many treatments have been described that all of them, frankly speaking, have questionable role. All of them have questionable role. What is effective is some kind of PDT. Rifampicin, because everybody tried, we also tried, but in 50% I got the response, 51% I did not. Rifampicin here is being given not for anti-tubercular action, but rifampicin increasing the metabolism of endogenous steroids. And that is how rifampicin in the dose of 300 milligram BD given for a couple of weeks, 3 weeks or so, then it may help. So this was one of my patients who had this angiogram done somewhere else, and we did this rifampicin 300 milligram BD for a couple of weeks, and patient did improve. But this is not all the patients of rifampicin do not improve. So therefore, it cannot become a standard of care. Only in desperate patients we may try. Patients are not willing for PDT, can't afford PDT. Patient has recurrent CSR and leak is in the central area. So this is patient who had, this was the OCT before, and this was the OCT later on. Intravenous injections, which are the most misused kind of injections for any kind of macular pathology, and I personally believe literature also says it's not a VEGF-related disease. CSR is not a VEGF-related disease, so therefore we should not. Although there are reports which show benefit, but there are equal number of reports which say there is no beneficial effect at all. So bevacizumab or Avastin, which people use, is actually does not make any scientific basis to be used in patients of CSR. Coming to the last model, that is PDT. PDT, if you give a standard PDT, there is a potential of hypoperfusion of the choriocapillaries. Therefore, what is recommended is give a low fluence PDT in such patients so that the perfusion of the choriocapillaries is there. So this is one patient who had received 3 injections of Avastin, and this is the angiogram at presentation. Since the leak was juxtafoveal, this was the OCT picture. We did this low fluence PDT, and you see this is a window defect here now, no leakage. And this is the OCT of the same patient. So the PDT low fluence did work in this. This is comparison of pre and post PDT. This is another patient. This lady had received 9 injections of Lucentis, and this is post PDT. So and vision also improved. This is another patient who had been subjected. This is a pachychoroid, so vision also improved. Another patient to show this. This is pre and this is post PDT. This is one of the doctors, actually medical doctors, where I had done the PDT. So we have now series of patients, actually more than 20-25, where we have been successful in treating patients of recurrent CSR with subfoveal leak on low fluence PDT, and believe me, the response has been nearly more than 95%. It's not that it's an occasional response. So the last slide is what is best for a chronic, as I said, low fluence PDT does work. Other options which I had listed with question mark, they can be tried if patient is not willing for PDT. This is just to repeat. First episode, acute episode, master inactivity, rule out steroid intake, rule out skin cream, inhalers, homeopathic medication, and recurrent CSR, if it is laserable, gentle laser. If not, low fluence PDT does work in these patients. Thank you very much for your kind attention.
Thank you, Dr. Lalit, for a very lucid talk on central serous retinopathy. One thing what I am realizing is the patient who received Avastin and who benefited from Avastin were actually pachychoroid patients.
Yeah.
And with more of knowledge and literature on pachychoroid, what we are realizing is these were patients of either pachychoroid central serous retinopathy or pachychoroid neovascularization. Any comments, sir?
Absolutely, because pachychoroid is a spectrum. I don't think pachychoroid is a specific disease. It may, transform one spectrum, one clinical picture to the other. There are, situations where patient may have initial typical CSR. You follow up long enough, they may, next visit after a couple of months, you may see a CNVM, especially on OCT angiography, you may see that. Or sometimes you may see on ICG a polyp coming up. So it's a clinical spectrum. It's not one disease of pachy.
Yeah.
You are right that all these 4 diseases have some kind of overlap also.
So what the concept which is coming is ki CSR, polypoidal choroidal vasculopathy, and pachychoroid neovascularization and pachychoroid epithelopathy are the spectrum of the same disease. And if you have a patient in group of neovascularization or PCV, these patients do respond to Avastin. And that's why some people say ki I gave Avastin and my patient responded.
Absolutely.
Actually, they have misdiagnosed that that's an advanced case of pachychoroid neovasculopathy or a PCV. With this, I will like to invite Dr. Christopher Brand to speak on diabetic macular edema. Dr. Christopher Brand is a consultant ophthalmologist with special interest in medical retina at the Royal Hampshire Hospital, Sheffield, UK. We are delighted to have such an enlightened faculty from UK, and he'll speak on diabetic macular edema.
Christopher is a guest speaker with us, and all the guest speakers, have been given 10 minutes talk in the respective instruction courses. Welcome.
Thank you very much. It's an honour and a pleasure to be speaking to you today on real-world diabetic macular edema data. These are my financial declarations. Okay, diabetes is a huge and growing problem. We see here that there will be an extra 205 million people with diabetes in 2035 than there were in 2014. If you look at Europe, 52 million people with diabetes, 1 in 3 undiagnosed, and 1 in 13 adults have diabetes, and the expenditure is huge. If we look at Southeast Asia, 75 million people with diabetes, 52% undiagnosed, 1 in 12 adults with diabetes, and again, a huge cost. If we look at the epidemiology in Europe, it's the 1/3 rule. 52.6 million people with diabetes. Approximately 1/3 of people with diabetes have diabetic retinopathy. About 1/3 with diabetic retinopathy have diabetic macular edema, and 1/3 of these have clinically significant macular edema. If we look at the clinically significant macular edema, we have 2 types: centre involving and non-centre involving. And if there's non-centre involving, we'll often recommend laser therapy. And if there is centre involving, we'd recommend intravitreal steroid or anti-VEGF. Now, what are we asking, or what do we need to know? The intervention of intravitreal injections for diabetic macular edema are costly and invasive. It's important to understand what visual outcomes are achieved. We need to understand how clinical trials translate into clinical practice in the real world. And also, we can give a real-world benchmark to compare local outcomes. So how do we do as an individual treating these patients? How do we do as a hospital, a region, or a country? So, how do we do this? We look at observational studies. Here's the advantages of an observational study. The follow-up can be longer and involve more patient years than a randomised controlled trial. They can reflect actual practice patterns, allow precise subset analysis, and larger cohorts enrolled can increase statistical power. Like every trial, there are disadvantages. The disadvantages of an observational study are the lack of randomisation can lead to large differences in patient characteristics between groups. Unobserved characteristics cannot be accounted for or controlled, and the length of follow-up required can result in loss of follow-up of some patients. Now, we often think of the randomised controlled trial as the gold standard. The groups are treated identically. The randomisation eliminates systematic differences between groups. There's blinding and double blinding, which eliminates systematic bias, and it includes a control group for comparison. But there are problems with these trials. They're restrictive due to their inclusion-exclusion criteria. Often they do not reflect the type of patient we will treat. Often patients in trials are young, healthier, more educated, and of a higher socioeconomic status than our target population. They can often be underpowered to detect important differences in outcome, often with low recruitment rate resulting in adequate sample size. And the follow-up criteria are much more strict in a randomised controlled trial than an observational study. So we have this continuum of evidence. We've got randomised controlled trials on one side, we've got observational trials on the other. And it allows us to assess clinical and cost effectiveness in the real world. So how will this apply to your community? Improved understanding of the benefit and the risk across a broader range of patients. Assessment of safety in the real world, which may show opportunities to identify rare outcomes or rare side effects, and also compare evidence against multiple other realistic alternatives. So here's an example. The analysis of results from the RISE and RIDE trials, the conclusion of the authors was the HbA1c does not affect visual outcome in diabetic macular edema. The trouble was their mean baseline HbA1c was 6.4%. A recent review of patients in the UK with late presentations of severe sight-threatening retinopathy, the HbA1c was 11.5% compared with a control of 8.4%. What I would say is, in the RISE and RIDE trial, the patients they were treating did not reflect the patients I'm treating, and I would say the patients you are treating. So I'm going to quote essentially from two trials. The Luminous trial is an ongoing 5-year multi-centre trial which uses Lucentis across all treatment indications. And here I'm looking at diabetic macular edema, and it represents countries from Canada and South America, the UK, Europe, Russia, Singapore, China, Japan and Australia. And there were 3 types of patients going into this trial. When they went in, they'd either never previously had Lucentis, they'd been previously on Lucentis, or had been on an alternative treatment. And what we see here is there is an age range of patients, over 85, under 50. This is now taking data from the UK Electronic Medical Retinal Group. This was 19 centres where there's over 3,000 eyes, more than 2,000 patients, and data was taken from electronic records and analysed. And what you see here is we're treating patients here in the UK that were 20 or 105. You don't put your 105-year-old patient in a trial. So how do these patients do? There's a wider range. So here at baseline, you may have a patient before you and you may be worried about giving them an injection because they've had a heart attack or stroke. What we see in the Luminous data was 7.4% of patients that had a heart attack received treatment. 6% had had a stroke. All were diabetic, as we would expect. 1 in 4 were obese and 2 in 3 had hypertension. Again, looking at the diabetic macular edema baseline visual acuity, the Luminous trial is sponsored by Novartis, and what they have done is taken patients with good vision, intermediate and reduced. Looking at the UK data, they gave a far wider range of visual acuity, 0 to 39 letters, 40 to 54, 55 to 69, or 70 to 100. And if you look at the number of eyes, there's significant number of eyes in each of those groups. Now, what we see here in the first year in the Luminous trial is whether you were treatment naive or not, the patients require high numbers of injections. And what we have to think sometimes is not think like a surgeon where you may see a patient once, operate and see them again. We have to think more like a physician in the sense of you're going to go on this treatment and you're going to be on it for a number of months, if not years. So we have to think differently about managing these patients. Not only do they require a high number of injections, they require a high number of visits. So it is quite intense, this management of these patients. We often, whenever we start a treatment, we should ask ourselves 2 questions. Are we going to make you better, or are we going to stop you getting worse? If you look to the right side of this slide, you will see that in over 90% of patients in the Luminous trial, we're good at stopping significant visual loss. If we now go to the left side of the slide, you will see that approximately 40 to 50% gained 5 letters, 1 in 4 to 40% gained 10, and 1 in 4 to 1 in 5 gained 15 letters. Now, one of the things of randomised controlled trials is they will often say what the mean visual acuity gain is. What I would say to you is, in some ways, that is a meaningless figure. If you look down the mean change in visual acuity on this slide, if you look at those with good vision, you will see that the mean change in vision was minus 2.4 letters. You would say, that's not very good, perhaps. Whereas if you look at the bottom, you will say some patients gained 11.8 or 15 letters. What this slide shows is, if you start with good vision, you end up with better vision. So if you look at your own data of your patients and you see that in your cohort, the patients have poor starting visions, what that's saying to you is your patient group either needs educating or better access to your service. If your patients have good baseline vision and they don't end up with good vision, you then need to look at the service you're delivering. So this group here, you can see that the mean change in vision was 4.4, but around that mean change, there are significant other changes. Looking at the UK group, similar thing occurs. The overall mean change in vision is plus 5 letters. Those with good vision, there was a slight loss. Those with poor vision, there was a gain. Looking at this data, we found that at baseline, 25% meets the UK driving standard, but after 1 year, that had risen to 33%. So if you're buying this service, you might say, why don't we only treat the bad eyes because we can make them better? However, if you treat the good eye, you may treat an individual who is working, able to continue work, able to continue driving, earning money for their family, and reduce the likelihood of mental illness. So these become big decisions for people that may fund these services. Change in central retinal thickness is as we might expect. There is a reduction in the swelling at the macula. It is important we treat the patient sometimes and not just the OCT or the result. So in diabetic macular edema, what's important to us is the visual acuity. In diabetic macular edema, if there is some residual fluid, that will not sometimes worry us as much as in other conditions like AMD, where it may be a sign of activity. So the other thing which is not addressed in this presentation, but we will need to address, is what is our treatment approach? Is it a reactive one where we give a loading phase of injections and then give further injections as needed? Or do we give fixed injections over a period of time with certain parameters that will determine whether we continue? Or do we do a treat and extend? We give 3 injections and then gradually extend the review interval and trying to keep the patient's macula dry. Or do we do a combination of what we may determine patient-specific, trying to deliver the needs for that individual patient rather than one size fits all? So in conclusion, if you use electronic medical records, you can mandate a collection of agreed data sets prospectively, collecting large volumes of real-life outcomes on patient characteristics, the therapy, the visual outcomes that can be later rapidly extracted for analysis. You can develop highly structured electronic medical records so you get a minimal data set. This data was collected as part of routine practice as it happened, and also it allows us to benchmark our service and look how we're doing compared to others. We mustn't be afraid of looking at our own service. When you're involved in studies like this, they can say, you are centre number X out of all these centres, and this is how you are comparing. So I think unless we truly look at the service we're delivering, it is the only way we can improve our service. Thank you for listening.
Thank you very much, sir. There is a lot of insight into real-world data. We will have more discussion after Anand presents his DME account. Now we will invite Dr. Raju, who is Director of Netra Spandana Eye Hospital, Bangalore, to deliver his talk on cystoid macular edema.
Very good morning. Let me start off with the clinical scenario. This patient was referred by our cataract section 4 to 6 weeks after an uneventful cataract surgery, probably, and the assistant or operating doctor personally sent a message, the fovea looks unhealthy and there is no improvement with refraction. So I had to face this disgruntled patient, and he was informed the cataract surgery and IOL is okay, some retinal problem exists, and our specialist will see you. And the retina specialist will need to cool tempers, get back the patient confidence, and find some very difficult questions. He will say, I was seeing better before cataract surgery. We now operate at 6/9 vision. He'll ask, anything wrong with this surgery? Then he'll go on to ask, will I recover vision? How long will it take to recover? And he'll keep on asking this question, anything wrong with this surgery? Could we have avoided this situation, and how to manage this patient? This is the brief overview of what I'll be talking. I'll just introduce to you the terminologies and how to manage this problem in a stepwise manner based on evidence. So, cystoid macular edema is a non-specific clinical finding. It results from a final common pathway of many intraocular diseases, which could be inflammatory or non-inflammatory. So most commonly, it's the post-surgical cystoid macular edema that we all would be treating. In the non-inflammatory category, the diabetic macular edema and RVO also can lead to cystoid changes. This is the broad working classification, and my talk would basically be concentrating on the post-surgical cystoid macular edema, which is also called as the Irving-Gass syndrome. This is one of the most frustrating and common of all complications. Intraoperative loss of vitreous or PC rupture is associated with increased risk and poor prognosis. The angiographic CME means the patient is asymptomatic. he doesn't have any decrease in vision, but he has detectable leakage when you do an angiography. A clinical CME is the patient has visual impairment and the diagnosis is confirmed on angiography as well as on the OCT. It's also important to remember that the thickness of CME correlates with this visual acuity rather than the extent on leakage on FFA. Coming to the presentation part, early CME, late CME, and chronic CME. A patient presenting less than 4 months would be considered as an early CME, and any patient who has got a CME that persists for more than 6 months would be called as a patient with chronic CME. And the patient has a chronic CME, the OCT picture also will change, and the spaces will fuse to form the foveal cyst. Coming to the management of CME, the diagnosis is easy. You have a typical history and typical biomicroscopic findings on OCT and FFA findings. The main aim of the treatment plan is to answer this question: why this patient has a cystoid macular edema? So it could be because of the operation-related causes, or it should be because of the patient factors. So you need to look at the complications as far as your operations are concerned, and look at the patient factors, the compliance, and comorbid conditions. So let's look at ourselves first. Was there a PC rupture? Was there a vitreous loss? And if you have these decentered IOLs, that means you have had a complicated cataract surgery. Look for retained cortex and iris tissue damage that you can look on slit lamp examinations. Sometimes you may have to do a good indirect to see if there is any small nuclear fragment or a cortex in the vitreous cavity. Use of adrenergic drugs during the surgery may also lead to cystoid macular edema. Sometimes in the event of a complication, the anterior segment surgeon usually doesn't change the medication schedule. So you may have to increase the dosage of corticosteroids or NSAIDs, but we don't do it because if it is the second surgery, the patient will compare. It was not given during the first surgery, now you are giving it, there must be something wrong. So usually the operating surgeons don't change the medications even if they know that they have had a problem. But remember, it can happen even after a perfectly done surgery. So coming to the patient factors, sometimes when you are operating on elderly patients, they have a higher risk of developing a CME. Second thing is, look at whether he is using the drops as prescribed. Sometimes you would have written as 2 hourly, but the patient may be putting it only 2 times a day. Sometimes we give the kit along with the medications. Once the drops are finished, the patient stops using the drops. So they say that the drops with the kit are over, so I stopped it, I didn't buy anything later. Then always review the other eye surgery notes. So if the other eye had a history of cystoid macular edema, there's a chance that this eye can have a cystoid macular edema also. So also rule out the comorbid conditions. And look for prostaglandin analogs in patients who are on treatment for glaucoma. This is a second case scenario. This patient had a drop in vision after initial improvement with a YAG laser. He had a YAG laser, vision improved, again the vision dropped. This patient had a cystoid macular edema. So even after a YAG cap, you can have a cystoid macular edema. Coming back to our patient, I saw everything. The patient had a perfectly done surgery, and I looked at the review notes. The patient had a 6/18 vision, and it was written the antechamber had occasional cells. But when I did a good slit lamp examination with the room lights off, then the AC reaction was 3+. So it's important to assess the extent of inflammation and to individualize the medication, treatment, and interval. As far as managing the pseudophakic CME, what is the stepwise approach? There's no standardized treatment or prophylactic protocol for CME. There are no RCTs with long-term follow-up. But most of the time, this is what we follow. We usually give a topical corticosteroids along with NSAIDs for usually 4 to 8 weeks. If it doesn't work, then think of giving a subcutaneous injection. Then some people also try oral azazolamide or oral steroids and NSAIDs. Next is the last, we think about the intravitreal injections and surgery for vitreous incarceration. So which of them is better? How do you treat? So whether you should treat with NSAID alone, steroids, or a combination. The combination with NSAIDs and steroids is better. And this patient post-DAG, you can see in 2 weeks' time, just on topical steroids and NSAIDs, had a good response. Coming to the prevention. So prevention and treatment are different. So you should know the difference. Here, the NSAIDs alone are better. If you want to prevent a patient from developing a CME, that is preoperatively. So NSAIDs are better. Now coming to which NSAID is better. The ketorolac has got a better prostaglandin inhibition and better penetration into the antechamber and vitreous. However, the bromfenac and nepafenac have got better market penetration. Coming to the anti-VEGF, there is no robust data to support its use of anti-VEGF. There are some positive results in recent studies, and I would say it should be reserved only for those unresponsive to conventional treatment modalities. Late CME. Late CME, this patient had a CME noted 1 year after cataract surgery, treated with topical and NSAIDs. This patient responded. And when the patient has refractory CME, refractory to the topical medication, then one can consider oral periocular steroids, intravitreal steroids, or intravitreal anti-VEGF, especially in patients who have DME. Coming to the use of dexamethasone. This study has shown that the patients who had chronic CME improved after dex implant. But however, one should be very careful when you're treating patients with chronic CME. This patient came 7 months post-cataract surgery with a multifocal IOL, 6/18 vision, treated with oral steroids, was not well tolerated, and we gave an intravitreal triamcinolone. Vision immediately improved to 6/6. 4 weeks after, the vision started to reduce, and when you look carefully at the iris margin, this is what was growing. The patient had a fungal infection. So in a chronic CME, one should be very much aware that inflammation produced by the fungal infection or propionibacterium can cause this problem. If you have a poor response, then one should consider the VMT. So if you are considering prophylaxis, for a normal patient, you should start NSAIDs 2 days before surgery, and if it is a high-risk cataract patient, at least 1 week before. So in these patients, make sure you look at the various risk factors and try to address them correctly. So answer this question, why this patient has a CME, and most of the times you'll be able to get a good response. Thank you.
Thank you, Raju. I'll ask audience, how do you manage, this is a routine problem in your cataract surgery. So how do you, somebody from the audience can tell what they do in cystoid macular edema? Anybody from the audience? Yeah. Meanwhile, I'll request Dr. Dinesh Talwar to set up his presentation. He'll be talking about age-related macular degeneration, which is one of the most common cause of blindness in USA and the second leading cause of blindness in India. Yes, please.
Prolonged treatment with NSAIDs and steroids for topical mainly. Well after the clinically and OCT CME has subsided.
So when do you give steroids, posterior subtenon, if it is not responding? What is the time frame after which?
6 weeks I wait.
Raju, any comments? 6 weeks or thereafter?
I usually try to wait. We usually monitor this patient on a 2-weekly interval, and we'll see the response. And usually, as you said correctly, by around 4 to 6 weeks is the time when we start thinking about whether we need to make a switch.
Switch from steroid, because many of the CMEs resolve by themselves. So when do you label them when to start the treatment, when to start steroids? Like 6 weeks, almost you will have an incidence of somewhere around 6%. But these tend to resolve by 8 to 10 weeks. So when do you tend to start treatment for cystoid macular edema? That's the main question.
No, we'll start treatment immediately.
Yeah.
Immediately.
Yeah, we start immediately. Once the patient is symptomatic and vision is not improving, we start.
Dr. Dinesh?
Yeah, see, you're not going to wait for CME to worsen before you start treatment. There are two situations only. One is preventive, where you start in high-risk cases a week before. In high-risk cases.
Yeah.
High-risk cases are those with, say, diabetic with some macular edema, ERMs, retinitis pigmentosa. These patients are all previous uveitis history. These patients need the topical NSAIDs to be started a week before the procedure and continued up to 12 weeks after. It's because that's the period in which, if you taper off, you could still get the CME again. So this is one. The second is treatment. Once you have a patient who's got a suboptimal improvement, you start on a combination of steroids and topical treatment. Watch the patient for 3 weeks. If you get even one line improvement, you're getting an improvement. Wait.
So
Wait
when do you put a patient on subtenon?
The moment on subtenon, I would give at least a 6-week trial of topical steroids and NSAIDs. And if in this time the patient is improving, then I will hold my hand. And I'll also document this change by OCT. Sometimes you can have that OCTs become normal, which is not becoming better. So you have to make sure you check that out also.
Dr. Malika, one thing, can you tell us, do you give some prophylaxis to the patient or a high-risk patient of cystoid macular edema?
Maybe only in the patient where the fellow eye has had post-operative CME, but otherwise I don't think in diabetics it makes much sense. Another thing I would like to say is that we have to be careful giving these kind of drops for diabetics because they are already having borderline nephropathy, and my nephrologist has many times told me to not use these drops.
Yeah, long-term NSAIDs
We're talking of topical treatment.
Yeah, topical also.
But topical treatment cannot cause nephropathy.
No,
yes, sir. Our nephrologists also basically caution us that there is some amount of absorption, like beta blockers.
I'm a little surprised about this statement because the dose that you're giving is a homeopathic dose. If that is so, then tomorrow they will blame you for doing the cataract surgery. You see, it cannot be that a homeopathic dose of an NSAID you're giving.
Sir, a homeopathic dose of beta blocker is also causing asthma.
True, but we're talking of compromising.
Sir, I think
let's cut off the discussion.
Actually, I think this is going too far in terms of relationship of worsening of
I think it's a
nephropathy.
controversial thing we'll discuss later. Meanwhile, I'll request Dr. Dinesh Talwar to start his talk.
Good morning, ladies and gentlemen. Choroidal neovascularization is a condition which we see very often. And what exactly is it? You have basically vessels growing from the choroid under the RP, breaking through and reaching the subretinal space. Now, the situation could be that it's starting under the RP and is still under the RP, which is the occult form. The second is when it's actually between the retina and the RP, which is the classic form. And sometimes you can have the abnormality arising within the retina itself. The commonest causes are ARMD, high myopia, inflammatory, and idiopathic. The important thing is why it's important for us is because basically this causes a leakage of fluid under or into the retina. And associated with that, it may have either subretinal or sub-RP hemorrhage. All of these will contribute to the vision loss of the patient. How does the patient present? The major symptoms are the scotoma, blurring of vision, and if the patient is very intelligent, he may even tell you straight metamorphopsia. And that is a very specific sign. So if the patient comes to you with a sudden blurring of vision or a scotoma which moves with the movement of the eye, that means not got an independent movement, it's not a floater, then you know you're dealing with a CNV. And the basic thing, the problem for the patient is he never totally blind, but he cannot see from the area. What he wants to see, he can't focus on. That's the area which becomes unknown. And metamorphosia is probably the most specific symptom for this. This is what you could see on a Amsler's grid. So the basic classification is occult, classic, minimally classic. Now just what do these three conditions look like? Predominantly classic, you see the lacework of network of vessels or leak starting early hyperfluorescence, and this increases in the late phase with blurring of the margins. This is classical. If you have no significant leakage in the early phase and the leakage becomes intense in the late phase, this is late leakage from an unknown source and is a form of occult CNV. The third form is where you have, starting in the mid phase, an irregular RP elevation with stippled fluorescence, and this persists with increase in the late phase. This is a fibrovascular PED. And finally, you can have a serous PED where it starts filling in the early phase, becomes more intense in the late phase, but the margins remain well defined. That's a serous PED. The important thing is, whichever form of CNV you may take, there's a 50% chance of losing vision to the level of less than 6/60 within 2 years. So what should you do? How should you approach your patient? Even a patient you consider as dry ARMD, it's worth doing an OCT to rule out an early CNV, because basically that's the ground from which it comes. So if you see some abnormality in the OCT, that's the kind of patient where you need a fluorescein angiography to make your first documentation and categorization of the patient. After that, you may not use this, but initially it's worth doing that. So this helps you to characterize not only what type of CNV you have, but also whether it's extrafoveal or subfoveal. And it's very important to be able to do that, because if you have an extrafoveal location, the best treatment even today is to burn it off, and it will not come back most of the times. So this is very important. However, if you have subfoveal or juxtafoveal CNVM, the treatment of choice is actually anti-VEGF agents, and the gold standard for that still remains Lucentis. A new drug, aflibercept, called Eylea also, is useful in non-responders, especially in occult CNV with PEDs. In all these patients, when you start anti-VEGF treatment, you must give at least 3 loading doses for your patients who have an active lesion with any degree of visual acuity. Even a patient with counting finger could improve to 618 or 612, so don't miss up with those. But once you've done that, what do you do? So after you've given the initial 3 doses, there are 3 scenarios that can happen. The first scenario is the vision improves and the lesion becomes dry. If that happens, you can now do this follow-up on a monthly basis, and you give PRN treatment only if there's a recurrence. So if there's no recurrence for the next 3 months, you can do what I call a continue and extend. That means you increase the period of follow-up from 4 to 6 weeks, then to 8, then to 10, and then finally to 12 weekly. 12 weekly follow-ups will continue. But if a recurrence occurs, you're going to give the injection and then again follow-up, which will continue the same way. The second type of behavior is that you've given the 3 loading doses, vision has improved or has become stable, but the lesion is not dry. OCT still shows subretinal fluid, intraretinal cavities. This you continue the monthly injections till the lesion becomes dry. And then you follow what we've given as the first paradigm. But supposing the lesion just stays stable, doesn't become worse, doesn't become better, this is where a trial of aflibercept is warranted. And if with that also you don't get an improvement, you know this is the best you can do in today's scenario. Put this patient on a treat and extend regime. Now you want to decrease the number of injections. So increase the duration between the injections till you reach quarterly injections. And that will continue. So, and you revert back to 4 weekly or 6 weekly depending on whether there's a recurrence at that point. That means it becomes worsened. The last category is patients in whom the vision is still decreased, lesion is active and it's not improving. Now these are patients where you could go straight to aflibercept if the patient can afford it. Maybe 3 initial monthly doses followed by bi-monthly doses as required. And if the patient cannot afford it, you may still have to continue with monthly injections of anti-VEGF agents. What does aflibercept do? For me, aflibercept is a rescue drug in patients who are not responding. So these are non-responders. This patient had received some 16 Lucentis. Was not changing at all. Aflibercept, when it came into the market, we decided to give it. 1 week post aflibercept, the fluid went off, and the RPED also started resolving, which had not happened in the previous injections. And then, once that reduced, with significantly reduced intraretinal cystic spaces, we found, despite that, the vision was not improving much. We shifted him back to Lucentis to maintain on a regular basis, to keep the cost low for the patient. The second patient was maintaining a 6/9 vision, and then with these multiple injections, he suddenly worsened to 6/18. Was given aflibercept, these intraretinal cystic cavities disappeared, and you see within a month it's almost gone. And then the vision also improved. Now this is a great thing to happen for us. So here we now, after this, again shifted him back to Lucentis and maintained him on Lucentis, giving aflibercept in a very small number of times. Now this is important because patients who with aflibercept, what we've noticed is that their chorioretinal atrophy is more. So if you give too much, you may actually, on the long term, harm your patient. So I prefer to use aflibercept as a rescue drug as and when I require. More important than knowing when to treat is knowing when not to treat. And these are the conditions. If you have a serous RPE detachment without any vision acuity loss, and a non-progressive lesion. Now this, if you see all the studies which have been done on ARMD, exudative ARMD, they mention when they talk about occult and minimally classic lesions, that progressive lesion, not stable lesions. They have not treated stable lesions. This is where you decide to keep watching carefully. If the vision is deteriorating or the OCT changes are progressing, you could consider treating. The second thing is you must know that now he's reached what he can gain. So if you have a macular scar and he's worsened to a point that the visual acuity is less than 360, you can leave this patient alone. Now something like this is not going to improve further. If you have a scar like this, and this is an old hemorrhage which is actually resolving, you can actually leave it. You don't really need to treat at this stage. Now in a PED, if you have a PED like this, you can see the macula is normal. Patient 6/6, minimal metamorphopsia. Watch this patient. Don't go ahead treating it. If you find a deterioration, you will need to treat it. What do you get after all this treatment? Patient to ye janna chahta hai, milega kya? Will I, spending so much money, do I get something? The fact is 2 to 3 year outcomes are excellent with all sorts of these drugs, and 10 to 15 letter improvement is possible in many of the patients. But what happens in the long term? Now this is the 7-UP trial which actually followed up these patients who were initially enlisted in the Marina and Anchor, followed them up all the way for more than 7 years. And what happens? If you follow these patients, you find that at the end of 7 years, a quarter of your patients, if they are treated properly, are still maintaining better than 6/12 vision. And that's a great thing to do. 1/3 have better than 6/18 vision, which is again a great thing. But 1/3 of them, despite all your treatment, would have had more than 3 lines loss. And an active lesion will be there in 68%. So the advice I give my patients of ARMD is, your treatment is indefinite. There is no such thing as a finite element in this treatment. Very few percent, only 20% or so will respond and not need treatments in the future. Now the important thing is that monthly follow-up is essential till the lesion heals, and then a 3-monthly lifelong period will continue. And the most important thing, which has saved more eyes than anything else, is a high index of suspicion for retreatment, which is a loss of BCVA of more than 5 letters, OCT evidence of new or persistent fluid, increase in CRT, new macular hemorrhage. Maybe you can't see anything on the OCT, but you see on the fundus photograph there's a new hemorrhage, deserves treatment. Or, and this is the most important, any subjective evidence of macular fluid. If the treating surgeon feels nahi kuch gadbad hai, he can still give it. Ladies and gentlemen, eternal vigil is the price we pay for maintaining vision in patients with CNV. Thank you very much.
Great talk. Next up, I invite Dr. Anand Rajendran to give his address in diabetic macular edema.
We'll take 2 questions if you, yes sir.
Retinal pigment epithelial detachment. So what you saw, the huge mound over there, and next to that the macula was normal. Now that's when you're not going to treat unless you find that there is some deterioration. Either metamorphopsia is deteriorating, OCT is deteriorating, or even slight change in visual acuity, something you document in front of you. So patient comes with 6 vision, call him 2 weeks later, see if he's okay, then make another 2 weeks, then 4-weekly follow-up. Or SOS, tell the patient you feel anything worse, come immediately.
So we have one more question we'll take.
So you don't like to switch between bevacizumab and ranibizumab, instead straight away going for
Yeah, we have a
active
little problem with bevacizumab for the last 1.5 years or so. I don't know whether it is specific to this country, but the number of cluster endophthalmitis cases that have happened with Avastin are so high that we have actually stopped Avastin. So that is the reason this switch from Avastin to Lucentis is not this thing. But yes, once in a while patients can respond when switched from Avastin to Lucentis. The fact is that Lucentis is a slightly better drug as compared to Avastin for management of ARMD also.
And the cases you have used the aflibercept, like as you were telling, there was more of a atrophy you see.
No, I said it happened. If you see the VIEW trial, the VIEW 2 trial had Asians in it. And in VIEW 2 trial, the 2 milligram aflibercept monthly resulted in improvement of the OCT changes. It dried the macula, but vision was not improving. It was the worst vision group. So what that implies is that you may dry the lesion, but you may get atrophy in the process. So that is why I'm very careful in using aflibercept in our group. I will not continue the way Lucentis you can continue to give on a long-term basis. Even with Lucentis in the IVEN trial, they found that geographic atrophy was more. But that could also be because it dried up. But here, it's drying up but causing vision loss. That is an important thing.
So we'll take questions towards the last if we have time. I'll request Dr. Anand Rajendran, who is a consultant, senior consultant at Arvind Eye Hospital, Madurai, to speak on diabetic macular edema.
Good morning, it's my pleasure here. So about diabetic macular edema, the approach I'm going to take is look at current basic principles governing DME treatment, and my talk has largely been supplemented by Dr. Brand's talk. And we have to know where we are coming from when we talk about guidelines for treating DME today. So that's why it's important to know these trials. Then look at the factors to assess how to strike and then the future directions. So basically from the trials, the guiding principles is, first of all, we know that RESOLVE clearly showed us ranibizumab has high efficacy versus SHAP, no doubt there. But the important trial, which I think everybody needs to know, is this erstwhile trial, Protocol I, which showed clearly that ranibizumab laser combination was definitely better than laser or the IBTA laser combination. That's one. Then deferring. When you do combination, how do you do it? Deferring a combination laser was better than prompt laser. That was also shown. All right. Now, this graph shows us that at the mean equity change at 2 years was that ranibizumab deferred was definitely better than prompt laser, and which is far better than these two. So deferring laser is not a bad idea and shows an advantage at year 2. And pharmacotherapy definitely scores over the laser invasive form. And this was seen even at 3 years. The same advantage was seen. So deferring laser advantage was seen at year 3 also. And then more recently at year 5 also. So there's no doubt that over 5 years, deferring a laser gives you an advantage. Next, even in terms of reducing the macular thickness, deferring laser was also better. So you have no doubt there. Now, early intense treatment. Should you be slow or should you be quick when you treat? Early intense treatment definitely reduces treatment burden later, as shown here. In the first year, in both the prompt as well as the deferred laser arms, early intense treatment, 8 and 9 injections, drastically reduce the number of injections later. So getting a grip on the disease early helps. And 33 to 43% of patients required no ranibizumab treatment in year 3. So there's a definite advantage to being aggressive early up. Higher safety issues for IVTA, everybody has no doubt about that. Much higher incidence of elevated IOP and glaucoma with the triamcinolone arm, as well as more than 1 in 2 patients developed required cataract surgery. Now, RISE and RIDE, in the untreated eyes, it showed us that it's never too late for giving or starting intravitreal anti-VEGF treatment. And chronicity is not as big an issue as we sometimes make it out to be. As shown clearly in this graph, these two are the ranibizumab arms, and this is the arm that did not receive any treatment, no treatment. Now see what happens. Almost miraculously, after 2 years of receiving no treatment, once this was opened up to Lucentis treatment, see what happens. It starts snaking up towards the ranibizumab arms. So it's never too late to start treatment. Also, when the same patients were open to treatment, macular edema, which resolved very minimally initially, suddenly nosedived, and then the macula started getting thinner and almost became as thin as the maculae in the ranibizumab arms. Now, Restore in lasered eyes, Rise and Ride were the sham arm was untreated. In Restore, the lasered eyes again showed an improvement post-treatment. You see here, these are the ranibizumab arms, and this was the arm which received only laser. And then moment it was open to Lucentis, vision starts improving. And see what happens at year 3. So this yellow plot was what received laser at the start. And here, ranibizumab at the start. And here these people received ranibizumab at the start. So at year 3, these two converge. So it makes no difference whether you start anti-VEGF 1 year later or you start it at the start. So they almost catch up. So starting anti-VEGF, even for a patient who's just been lasered for a year and had no other anti-VEGF, definitely has bang for buck. So there's this concept that adding laser reduces the number of re-injections. You see here, in all the arms, the number of re-injections is almost the same. So that argument also doesn't hold. Bold study showed a high efficacy for bevacizumab for DME, and we won't go beyond that. Now, most importantly, the DRCR protocol T, the 2-year results came out recently, and this is the most happening trial and has, caught a lot of attention because it's brought in the new player, aflibercept. Now, at year 1, previously when we saw this, was what a lot of us were chirping about, that aflibercept was significantly better than ranibizumab and significantly better than bevacizumab at year 1 for patients who had 20/50 or worse vision. That means patients who had 20/50 or worse, it was definitely advantageous to give aflibercept. But a year down, look what happens. Aflibercept starts losing that advantage. Ranibizumab catches up. So at the 2 years, Novartis people are pretty happy to say that aflibercept has no real significant advantage over ranibizumab and it's more the same. But still people seem to tend to move towards aflibercept. Now, so you have higher efficacy, aflibercept versus ranibizumab in year 1, but that advantage was not seen in year 2. Post hoc analysis in eyes with central CST greater than 400 microns showed equity gains for aflibercept over the other two, and it also showed us bevacizumab reduces macular thickness the least. Now, quickly looking at how you should look at your individual patient, the patient who's sitting in front of you. First of all, the clinical profile, obviously. Look at the fundus picture, the OCT, FFA pictures, the best corrected equity, fellow eye status is important. Look at the body, the systemic profile, and of course, rule out masqueraders. Also look at the dosing history, the pathology, the drug use, dosing strategy, patient factors, compliance and financial issues are going to be variant. Now, in terms of the clinical profile, look at what I call the mitigating factors and the encouraging factors. If you have these RP degeneration, macular atrophy, subfibrosis, macular ischemia, etc., then you probably should desist and not really chase after that eye. Whereas if you have encouraging factors, the pure clean edema with or without subretinal fluid and suboptimal vision, what I call between 618 to 4/60, perhaps you can pursue these patients. Mitigating factors like macular ischemia, subfibrosis, hard exudate, clumps in the fovea, outer retinal tubulations, foveal atrophy, vitreomacular traction, and ERM, the last two being surgical conditions. This is situations in which you really wouldn't want to keep injecting very aggressively. Looking at the fellow eye is also important because if the fellow eye has good vision, maybe you won't chase so aggressively. If the patient is one-eyed, on the other hand, that's only eye, then you might want to pursue. So your philosophy comes in here. Systemically, you'll need to know whether there's a history of glitter zones because that can induce edema, nephropathy, hypertension, anemia. All these need to be controlled, stroke, etc. Then most importantly, you need to rule out masqueraders. You have to keep an eye out. To rule out hypertension, control that. Mactel can often be confused, rule that out. X-linked retinoschisis with vertical septate sciatic cavities, rule that out because these can also be confusing. And this is just a management mantra that I've just put up. So you start with monthly injections. If the patient is stable, that means equity or OCT is unchanged over 2 or 3 visits, then you can either, depending on whether you want to be proactive, depending on the mitigating factors or the encouraging factors. If there are mitigating factors, then you might want to wait and extend. If there are encouraging factors, you can take a proactive role and do treat and extend. Whereas if it's unstable, you can go back to the monthly injection. And in both of these, in wait and extend as well as treat and extend, if the eye is stable, in both this you could extend up to 3 months. Whereas if it's unstable, in both these you could go back to this treat and extend. So this is just a rough rule of the thumb kind of policy you could use. So if the dosing is inadequate or healthy, re-inject. If the dosing is adequate, you could switch it, and the patient is still refractory, you could switch it, Avastin to Accentrix, or the other way around. Aflibercept is another thing, but it's pretty expensive. So just examples from my practice where, a patient who was on Avastin benefited from Lucentis and vice versa was also true. Though this example, obviously there'll be lesser cases in this pool. Elderly Sotafakes, intravitreal triamcinolone, Ozurdex is an option, especially for vitrectomized eyes, and that's its USP. And Ozurdex, from this study, we know that it does very well in post-vitrectomized. In fact, this is the only drug which can really make sense in a vitrectomized where there's no vitreous reservoir. The MEAD study shows that Ozurdex is also useful in patients who have already had treatments with laser, anti-VEGF, etc. Then this question which keeps coming about, what about combining anti-VEGF and IVTA? Now, all these three studies, and the most recent study, Garoon, clearly shows over a large set of patients, 192 eyes, that adding IV to Avastin offers no real significant advantage. Diffuse DME is one place where one must think of combination therapy, and if you're thinking of IVTA, then again, as I showed, deferred laser makes more sense, and if you're doing laser, you could do it for non-center involving DME. ERM, VMT are surgical conditions, vitrectomy, and of course you need to rule out the masculators. And I just like to bring this concept of micropulse subthreshold laser. There's been a lot of interest on this. It comes as diode 810 or yellow 577 nanometers. We use that, and we've had mixed results. Duty cycles in literature you have 5, 10, and 15%. We prefer to use 5%. You do a contiguous treatment. There's less RP damage as shown on negative yield on autofluorescence and microperimetry. So, in summary, these are the management mantras for refractory. Anti-VEGF therapy is clearly the mainstay. Refractory DME, you would go with, if dosing is inadequate, you would go, you'd go for re-injections. It's adequate, switch it. As I mentioned earlier, elderly pseudofakes, diffuse DME, combination treatment. The other alternatives, which, have mixed results, dose, height, drug, cocktail, etc. And future directions, of course, aflibercept have just come in. Subthreshold micropulse, as I mentioned, Iluvien, ocreplasmin without, and Fasudil is a Rho kinase inhibitor. All these are in the market. Thank you.
Thank you, Anand. We don't have time actually, so we will first complete the lectures. And then if there's any time, we'll use that for discussion. Dr. Malika will now tell us about
good morning, everyone.
Macular edema following BRVO, vascular occlusions.
Good morning, everyone. I'd like to thank Dr. Verma for this opportunity and Dr. Talwar and others on the dais. So I'll speak mostly about the practical points. There are three types of venous occlusions: the central retinal vein occlusion, hemicentral retinal vein occlusion, and the branch retinal vein occlusion. The only thing important to know is that the macular edema following hemiretinal vein occlusion is to be treated as if it is in BRVO, whereas it can lead to neovascular complications like CRVO. These are the various trials which have shown the results of treatment, whether with anti-VEGF or with steroid, are much better than no treatment. And by treatment, we mean injections. And these are the results for all the trials which show far superior visual improvement with treatment as versus no treatment. Same for Ozurdex implant. So ultimately, the treatment is injections, and we have these three options for anti-VEGF injections, and for targeting inflammation, we have these two options. So a typical case of central retinal vein occlusion when it comes to us, usually phakic at first presentation. We should rule out glaucoma of any type, very common in these patients, and systemic diseases, and we start the treatment. If it's a phakic patient, I prefer anti-VEGF because the risk of cataract formation. In any case, anti-VEGF is superior to start with, but if cost is an issue, sometimes we can offer steroid because of its longer duration of action, and hence the number of injections and cost coming down. So this is anti-VEGF injection, usually lasts for 4 to 6 weeks, and the patient gets several injections. And if the patient is pseudophakic or becomes pseudophakic along the way, then we can shift to steroid, either triamcinolone, acetonide, or Ozurdex. And here we give the benefit of increased gap between injections. And these are patients who are maintained for several years with twice-a-year injections. Now, how does BRVO or HRVO differ? After the injection, we do follow up with a laser once their macula is flat. because the BRVO study group has shown significant improvement, long-term benefit of laser. It reduces the number of need for future injections. For the injections, you may or may not do for the laser, you may or may not do an angiogram, because in BRVO, it's fairly straightforward that you have to treat this area. And if you have to do an angio, it should not be done within 3 months of giving an injection, because that would reduce your dye leakage and the angio would be not very reliable. Can laser replace anti-VEGF injections? No, this is a recent study which showed that if you give aflibercept versus only laser, the results are not comparable. So laser can only supplement injections. Laser cannot replace injections even in BRVO. So a couple of important points which come out from these various studies. Early treatment in retinal vein occlusion for the macular edema is extremely important. If you treat 6 months down the line, you may get the same anatomical improvement but not the visual improvement. So early treatment is also important immediately after the diagnosis. We should not give up the injection or the drug in 2 injections or 3 injections. Most of the benefit is seen only after 4 to 5 months of treatment, monthly treatments. So we should give that much time and that many injections before shifting the drug. Also, we should not tell the patient or expect that every month this will go on indefinitely. It was found in the recent studies that in the first 5 months they gave every month, but then in the next 6 months they only required it 2.5 times in the next 6 months to maintain a dry macula. So the number of injections will come down after the first few loading injections. And this is true even with a steroid implant, where we say it lasts only for 3 months, but up to 20% of the patients could maintain their macula dry with 1 injection. CRVO needs more frequent review even in the 2nd and 3rd year of therapy, as was found in these trials. We cannot just say that come 3 monthly, which we can for BRVO, because the patient starts losing vision. So in short, there should be a prompt injection, and prefer anti-VEGF, especially if it is an ischemic case, to prevent progression to neovascular glaucoma. A few slides about aflibercept. This is a new agent. It is as good as any other agent in a given case. But when you are dealing with a refractory case not responding to Lucentis or Avastin, there it has some advantages because of these theoretical benefits. I think all of us know, so I won't discuss this. So you see my case where we were treating with monthly Lucentis, not getting a response, and then with 1 injection, you see the response with aflibercept. So these are the various studies which have shown that switching to aflibercept in refractory cases gives a benefit over the other 2 drugs, Avastin and Lucentis, in refractory cases. Similarly, in a vitrectomized eye, aflibercept is the only practical anti-VEGF choice. The other 2 drugs do not remain more than a few hours to days. So in a vitrectomized eye, if you have to use an anti-VEGF, aflibercept is the choice. Systemic exposure is the safest is only Lucentis. If you have a patient with cardiovascular risk factors, it clears from the blood most rapidly and causes the smallest alteration in blood VEGF levels. Steroids can be added. I often do it to reduce the number of injections and to get a better drying if anti-VEGF is not able to achieve it. A slide about need for laser, peripheral laser with peripheral ischemia in cases of refractory macular edema. This has found to be more theoretical and has not really led to a decrease in the number of injections or improvement in vision. And there is no benefit found from increasing the dose of Lucentis. And this is the last slide to show that sometimes we think that there is a traction and we have to operate, and that's causing the macular edema. But sometimes just by giving injections or doing laser, there is a release of the traction. So we do not necessarily need surgery in every case of traction. We should try medical therapy. Thank you.
Thank you, Malika. Because of shortage of time, we'll proceed directly to Avninder. Dr. Avninder Gupta is speaking on epiretinal membrane. And I will make a special request to you to try to cover a minute or 2 from your presentation.
Yeah, sure, sir. Good morning, everybody. What I'll be talking is management of epiretinal membrane. Epiretinal membrane was first described by Ivanov in 1865. The incidence is 2% in patients aged 50 years and 20 years of patients above 70 years. Bilateral involvement occurs in 20% of patients. The condition is usually idiopathic, and there is a list of causes of epiretinal membrane, which I won't go through. Patient usually are asymptomatic. Majority of the patients are asymptomatic. 5% of the patient will have vision less than 660. There is a reduction in vision, and the most common complaint the patient has is of metamorphopsia. And if the patient comes with a complaint of metamorphopsia with decreased vision, these are the patients which you should take up for surgery. It usually presents with a yellowish-white sheen at the posterior pole. If you see carefully, the vessels get straightened up and the vascular arcades get collapsed because of the traction of epiretinal membrane. There can be a stria hypertrophy of the macula. Many a times you will find intraretinal hemorrhage with cystoid macular edema. Pseudomacular holes can occur in 8% of cases and PVD in 75% of cases. Coming to the pathogenesis of epiretinal membrane, RP cell migration is known to cause epiretinal membrane fibrosis in most of the patient. The most common investigation what we do in epiretinal membrane is an OCT. If you see on OCT, there will be a loss of foveal contour, and you can see a well-defined membrane on ocular coherence tomography. FA will show leakage in late phase. Asymptomatic ERM, like if the patient have ERM, you are diagnosing it, but patient does not complain of any metamorphopsia or decreased vision. These patients need not be taken up for surgery or advised for surgery. The indications for surgery are if the vision is less than 64, if there is a gross metamorphopsia, and if you see a thick epiretinal membrane, then these patients should be advised vitrectomy with ERM peeling. Here is a patient, you can see an epiretinal membrane. OCT shows a thick ERM, and we advise this patient surgery to this patient. First, the vitrectomy is done. Then we use a 25 gauge MVR to lift up the membrane. You can see the membrane here. We are creating an edge of the membrane. Once the edge of the membrane is created, then it's easy to hold the membrane. Once the edge of the membrane is lifted up, then we use an Eckhart forceps to peel the membrane. It's important that you don't pull the membrane anterior posteriorly. You have to peel the membrane tangentially, because if you pull the membrane anterior posteriorly, you can create breaks or rip in the retina. So always go ahead and peel tangentially. I lose the view of epiretinal membrane, so I use a BBG dye. You can see there is a staining of the epiretinal membrane, and I am now peeling this membrane in toto. Many times during peeling you lose the membrane. Again you will have to create the edge of the membrane and remove this epiretinal membrane in toto. I have left the membrane here, so I am creating an edge with a diamond dusted membrane scratcher, and then again I lift the membrane and remove this membrane in toto. You can see 1 week post-operatively, the OCT pictures have improved, the vision has improved from 636 to 624, and these are 1 month post-op pictures. You can see on return of foveal contour, and this patient, the vision has improved to 612. This is another patient of epiretinal membrane. We have done a VR surgery in this patient, and now what we have done, a fluid air exchange, and I am putting a reti-blue to stain the epiretinal membrane, which will define where the epiretinal membrane is there. You can see I am creating an edge with a 25 gauge MVR. Once the edge is created, it is held with the help of an Eckhart forceps, and you have to peel this membrane tangentially. You can see beautifully how the membrane is getting peeled from the retinal surface. You can see the traction coming once we are peeling. You don't have to pull hard, because if you tend to pull hard, you can create iatrogenic breaks. And whole of the epiretinal membrane comes in one go. And you can see the extent of membrane here. Coming to the result, visual acuity improvement occurs by 2 lines in 74% of cases. There is no improvement in vision in 24% of cases. Better results were seen in idiopathic epiretinal membrane. I won't go into the prognostic factors. Complications can be intraoperative or postoperative. Intraoperative complications like vitreous hemorrhage, peripheral posterior retinal breaks can occur. Postoperative complication, most commonly you will have cataract, RD, infection and recurrence in 5% of cases. Here is a patient, what you can see, the membrane is too hard and I am trying to pull the membrane but it's not peeling off. So I now use an epiretinal membrane, MVR blade to lift up the membrane. I am not touching the retina, but you will see the bleed coming. So see, the bleed comes and you can create a complication like this, but and you will have to manage. So this is not an easy surgery to do. Thank you very much.
Thank you, Dr. Avnindra. In the interest of time, we'll move straight ahead to Dr. Gopal Pillai, who will speak to us on macular holes.
Thank you very much, Anand. Macular hole is a full thickness defect right at the macula, a round defect, and Knapp was the first person who described it. Its peak incidence is at the 7th decade. Females, for some reason, it's more common, and the prevalence is approximately 3 per 1,000 individuals. Idiopathic macular holes are the most common, in which the tangential traction is, as we know, over a period of time. But there are other causes, rare causes, post-detachment, post-pneumatic retinopexy, Best disease, some of the other causes. The pathogenesis which is most held right now would be the Donald-Gass tangential traction theory, where he divided the idiopathic macular holes into 4 groups in the pre-OCT era based on stereoscopic biomicroscopy. And stage 1A had the yellow spot at the center. Stage 1B had a ring, more of a ring and a spot. And then stage 2 was a lamellar early macular hole with macular vitriofoveal separation. Stage 3 was a full thickness macular hole without PVD, and stage 4 with PVD. Clinically, we can diagnose it with Watsky-Allen test or a laser aim beaming test. That defective area does not have any sensory perception. OCT is right now the gold standard. You can know that stage 1A, stage 1B where there is a little more separation, stage 2 where there is an eccentric hole which is coming in. This is a stage 2. Stage 3 where there is an operculum on the surface, and stage 4 where there is a total hole with a total PVD, more than 400 micrometers in diameter. So these are the stages of a macular hole. You could use other tests like Amsler's grid, fluorescent angiography, or other tests like that. Natural course, stage 1, some of the stage 1 holes may close, but most of the stage 2, 3 and 4, stage 2 holes, and later will go on to stage 4 holes, and they will progress, and finally the central reading visual acuity will fall down. And so, in 2001, the American Academy released a technology assessment which supports surgery for stage 2, 3 and 4 and close observation in stage 1. So right now the indications would be stage 2 and 3 idiopathic, 2, 3 and 4 idiopathic macular holes with decrease of vision. There may be some recurrence of holes after surgery, traumatic holes, myopic macular holes. There is a visual acuity cutoff based on each surgeon and macular hole size. Generally the steps would include core vitrectomy first, then triamcinolone assisted or non-assisted PVD induction, and then vitrectomy just beyond the equator, internal limiting membrane peeling with or without staining, and finishing with a air fluid exchange. And in most surgeons, they use an SF6 or a C3F8. ILM removal during macular hole surgery, initially there was use of blood or serum or mechanical apposition of the hole, but ILM peeling as a standard technology was basically came out in 2006, and after that the whole the results of the macular hole increased tremendously. You can see here that triamcinolone has been put in, and we are inducing a PVD, and here after the induction of a PVD, I am using a scratch technique to actually take a little bit of a ILM there. So you pinch and peel to have a small edge here, and then you could do that. So then it is about removing the ILM completely around the hole to remove all the tangential traction on the hole, and later on you can use, you can basically enlarge that ILM peel area. So this just use triamcinolone, but more frequently now we are using brilliant blue-green, which is actually aided us so well. You can see here again a pinch and peel technique, a small pinch and a peel, and then initially starting on that particular area. So we make a small here, like here also, a small edge is created, and then the hole is peeled across the ILM is peeled across the hole. You could use certain variations. This is where blood was used to stain the ILM, and you could again have a very good stain and remove the ILM in toto. Here, this video courtesy to Raju. This is an inverted flap technique, wherein you are all around, you are peeling the ILM and not removing the ILM very close to the hole and putting that back into the hole. In special situations, sometimes in retinal detachment or in PDR, you may require to have macular hole ILM removal. Complications, they may end up in retinal tears in PVD. As in any case of vitrectomy, you could have endophthalmitis. Long-term complications may have cataract. In a lot of patients in whom gas has been put in, you could have retinal, there can be cataract. 2 to 10% risk of repaired macular hole reopening at a later date is there. Less frequent surgical complications may include photic toxicity or exudative detachments or glaucoma or maybe retinal detachment, etc. Kang described 2 types of hole closures, type 1 and type 2. I will go into this is a type 1 closure, which is a more uniform type of a closure where almost normal macular morphology is attained and the visual recovery is maximum, and a type 2 closure where sometimes it's a V pattern or a W pattern, where the tissue at the center is slightly less, and which is also accompanied by lesser visual recovery. The factors determining visual and anatomical results would be duration of symptoms. Duration of macular hole is a very important thing. Size of the hole, larger the hole, anatomical hole closure itself is more difficult. Stage 2 holes just closed by vitrectomy even without gas, whereas stage 4 holes, long-standing holes may require some mechanical assistance like gas, positioning, etc. There are now methods like hole factor, ISOS junction, which is functional, very important on OCT. If the ISOS junction is defective, then there is no point in operating the hole because that we are not going to get back good visual recovery. Macular hole closure is 2.59 times with ILM peeling. Hole closure rates 3.12 times more for holes less than 6 months old, 4.94 times more for stage 2 holes, and 2.5 times more for stage 3 holes. Do we not need prone positioning? There are a lot of studies on that. Some people now say that macular holes does not require positioning if the ILM is peeled quite well. New is 27 gauge for macular holes, case selection based on OCT findings, customized ILM area. Dr. Shubhendu here has presented a paper on that, limited prone positioning and combining vitreous surgery with cataract surgery. Thank you very much.
Thank you, Dr. Gopal, and I think we've now reached the end of our time, so we'll not be able to discuss much. We'll have to stop now, and the new session will now start. Thank you very much, ladies and gentlemen, for being here today.